Okay, hi guys. We're gonna go ahead and start. I'm so excited to have you guys here today. So if you don't know who I am, my name is Nanika Kumar and I am the committee chair of the Footprints Buddy and Support Program. So I wanted to welcome our second annual Pediatric Illness Forum speakers. We have some amazing speakers today. We have doctors, PAs, nurses, and even a community outreach partner. So we're so very excited. Although this is a very new way that we're doing it, we did have one last year, and obviously it was in person, so we kind of had to adjust and make it a little more social distancing wise. But regardless of that, we are so excited. And even with the different platform, we're so excited to have you here. We're so excited to educate you guys, have some fun. We have absolutely amazing speakers today. I want to thank the first four of you guys for being here today. This forum could not happen without you guys. We're so grateful for the time that you took out of today. I know you guys have very busy schedules. So the fact that you took like an hour or two out of your day to do this really means a lot to us. And I just want to know how much we appreciate you guys and how so excited we are to hear you. We've been waiting for this for about a month. So we're so elated to hear about your experiences and anything that you could share with us, since most of us are most likely going into the medical field, if not. So your experiences, the information you can give us is invaluable. And again, just so thankful, so grateful.
Hi, everyone. I'm Hannah Diasti. I'm the president of the Footprints Buddy and Support Program. Just to sort of reiterate everything that was just said, we're super excited to have you all here, and this is honestly an amazing turnout. So I'm really happy about that. September is Childhood Cancer Awareness Month, like I'm sure most of you know. So as Footprints volunteers, a large portion of our patients who we volunteer with on the immunocompromised unit are part of that community. So we really wanted to sort of hold this event tonight in honor of all pediatric patients, and to sort of educate our community and all of our audience members here tonight through insight to various perspectives of the people who play a role in the pediatric health experience. So like was said before, we'll have physicians, PAs, nurses, and then community foundation partners, and even patients themselves speaking tonight and tomorrow night, because we know that pediatric health is an interdisciplinary field, and there are a lot of people that participate in that journey. So just to give a quick rundown of how tonight's event is going to work, we're going to have 4 speakers tonight who will share their experience. And at the end of every segment, there's going to be a short Q&A session for that specific speaker. So if you come up with any questions while they're speaking, just go ahead and drop it in the chat. We ask that you stay muted during the whole event. I think there are like over 80 people here, so we're going to just keep everyone muted for now. And then at the end of every speaking segment, we'll go through a few questions, and then we'll move on to the next speaker. So we'll go ahead and get started with that. So our first speaker of the night for the first day of the Pediatric Illness Forum is Dr. Moiz Mustafa. Dr. Moiz Mustafa is a pediatric surgeon, and he's an assistant professor at the UF College of Medicine. I've had the great pleasure of shadowing Dr. Mustafa, and I can tell you that he truly embodies what it means to uphold quality care for patients. So we're super excited to have him to speak on behalf of his experience today. So please give it up for Dr. Moiz Mustafa.
Thank you very much, Hannah, and thank you very much, Anika, for inviting me to this. Can everyone hear me? Just give me a thumbs up if you can. All right, great, fantastic. I'm really excited to be here and to share my experience with you all. When I was first asked about this, I didn't quite know exactly what it is that you wanted, whether or not it was specifically cancer patients and immunocompromised patients, or in general taking care of pediatric patients. So I kind of went the latter way, which is in general about pediatric patients. Hannah already has some experience. She's come and shadowed me. I know a number of you probably have had some experiences also in the Children's Hospital, so you've got a little taste of what it is to be a provider for pediatric patients. So as she said, I'm one of the pediatric surgeons here. Our pediatric surgery division has a website where you can, see both myself as well as my colleagues. Many of us have intro videos that you can see. Link to it through either the divisional website or even through the UF Health YouTube site. And we also have a Twitter feed as well. So if you wanted to follow, you can see some of the happenings on our side. So I wanted to let you know what being a pediatric surgeon is all about. I'm going to go ahead and start by, telling you about myself. I am a pediatric surgeon here at Shands, and I've been here since August of 2016, so I'm starting my 5th year here. I had done my undergraduate degree in chemical biology at a school called Stevens Tech in Hoboken, New Jersey, and I did my medical school in New Jersey as well, at New Jersey Medical School. I was a traditional med school applicant, so I did my 4 years of undergrad and went straight into med school. I then did my residency in general surgery at University of Rochester. I'll tell you a little bit more about residency later on, but I spent 5 years in Rochester. My first 3 I spent there. Then I spent 2 years away in Philadelphia doing a research fellowship for 2 years. Then I went back to Rochester to finish my final 2 years of my residency. After I finished my residency, I went to do my fellowship in pediatric surgery in Houston, Texas. And I graduated from there and came here in 2016. So what does a pediatric surgeon do? We pretty much do a lot of stuff. We are the last true general surgeons that practice general surgery. General surgery is often referred to as sort of abdominal type surgery. Besides that, we do colorectal surgery, thoracic surgery, surgical oncology, or the immunocompromised and the cancer patients, trauma surgery, burn surgery, neonatal, so newborns, fetal surgery. We don't do it here, but there are centers that do fetal surgery where we actually, as surgeons, operate on fetuses in the womb. So it's pretty mind-blowing stuff. Pediatric surgeons also do bariatric surgery, endocrine surgery, and then some of them also do transplant surgery depending on their training. So it's a pretty broad scope of practice. Having said that, you might want to know, okay, well, we do all that stuff. What do you not do? Well, we don't do neurosurgery, so we don't operate on the brain. We don't operate on the spine or the spinal cord. We don't do cardiac surgery. So although we operate in the chest, we don't operate on the heart itself. We don't do orthopedic surgery or bone surgery. Ophthalmology is also a specialty of surgery, and we don't do that, so we don't operate on the eyes. We don't do complex ENT surgery, but we do have some overlap of procedures with ENT surgery, and that includes endocrine surgery. That means operating on the thyroid, the parathyroid, as well as neck lesions that can arise that are remnants from endocrine glands. We do some urology type surgery, but not the complex stuff. Some of the overlap might be things like inguinal hernias, circumcisions, even some bladder and sort of congenital remnants of bladder abnormalities. We also do some GYN type stuff, but not the specialized or complex. So we do a lot of stuff, and it's a really great field, a very rewarding field to be in. If anyone's interested, we'd love to have you come and chat and learn more about it. So how do you become a pediatric surgeon? I already told you what I did, my path. And it is a lot of school, a lot of time in training and education. So like I mentioned for myself, I did the 4 years undergraduate degree and then went into my med school as a traditional student. There are people that do combined programs. I don't know if we have one here at UF, but there might be. I know there's some sort of program that I think students can come in and get into the med school, but I don't know if it shaves off any time. Some places it actually shaves off time. So instead of doing 4 years undergrad and 4 years med school, you can actually do it in combined time, and it takes less time, maybe 7 years. I don't know if any do it in 6, but I think 7 is definitely an option that's available to people. Then you do general surgery training. General surgery is 5 years of clinical time and 2 years of research time, like I mentioned. Some programs actually have it built in, so you stay at one location for the entire time. I chose to go away, and I went to another institution to do my research time. After you finish your general surgery residency, you now become what's known as board eligible, and once you pass your boards, you become what's known as a board certified general surgeon. To then become a pediatric surgeon, you have to go into your pediatric surgery, which is another 2 years. That's a fellowship, or sometimes referred to as a residency as well. and that's 2 years. And then you're finally done. And now you get to practice what you've been training for all that time. So why do we do it? Well, we do it for the kids. It's an extremely rewarding profession, first and foremost, because of all the kids that we take care of, and for the parents of those kids who are worried about their child. When I was a student in medical school, the program director for the surgery residency told us all it is a great honor to be a surgeon and to have somebody willingly come to you and have you essentially violate their body in terms of making a decision and injure them in a way, but all for the good, of course, of treating whatever disease process they have. So it's an extreme honor to be able to do that. And that's somebody who comes to you for themselves, let alone a parent who brings their child to you. So it's an extreme privilege and honor to do this, and we really take great pride in what we do for the kids. And next slide. And besides that, we work with a lot of people who are like-minded, a lot of people who really care about working with children. One of the best things about working with children is we get to have fun. You see kids obviously when they're sick, but you see them when they're doing well, and they do pretty easily. They recover very well. And it's really great to have fun with the kids and to be playful with them and so forth. Besides that, like I mentioned, it's a very broad scope of practice. So every day is something new. You know, today I operated on 2 teenagers. Tomorrow I'm operating on a 6-month-old. So it's really something great. And there's a lot of stuff that we see, that we learn about in the textbooks, and sometimes stuff doesn't really follow what the textbook explanation is or descriptions are. Sometimes we find congenital anomalies that are not quite what we expect. And those can be very complex cases with intricate operative procedures that are needed, sometimes even creative solutions for those things. And often we deal with things in a very multidisciplinary approach. So those that have either been on the oncology or the cancer ward, or seen some of those patients or worked with those physicians, we all work together, and we all work together for the children. We do outreach as well. So pediatric surgery is one of those fields where there's a lot that we can do. From a trauma perspective, there's injury prevention. There's unfortunately patients that come in because of neglect or abuse that we take care of. And we work on many levels with regards to taking care of these kids, local level, state level, and even national level. And we have fun. We have lots of fun doing what we do. This is just a picture of us on rounds while I was a fellow, and I just wanted to highlight this. You see a lot of smiling faces. It's a lot of responsibility what we do, but we have fun doing it. We do it, and we do our best doing it, and we get along. The next slide is, you know, we just have fun in the operating room. I mean, kids come to the OR and they've got, you know, toys in their hand or so forth, and we try to distract them while they're going to sleep for anesthesia and so forth. And it's a great way of staying young, to be honest, right? I mean, you're playful with the kids, and you stay young doing it. Next slide. So we see a lot of cool stuff, and I didn't want to have a presentation without showing you some of that cool stuff. To kind of pique your interest in what we do. This is a picture of a patient of mine from my residency, and that's an intestinal atresia. So sometimes the bowels, which are supposed to be in continuity from the mouth to the anus, sometimes there's a blockage somewhere along the way because of a congenital problem. And this here specifically is that you can see that very wide part of that pink area. I don't have a cursor to show you, but yeah, the wide area in the middle is part of the bowel that's dilated or distended, and that's because just past it is a very narrow area, so there's an obstruction there. It's a very rewarding case that we do, and this is one of those things that's congenital, so kids are born with it. Sometimes we even know about this stuff prenatally because they have ultrasounds when mom is pregnant, they have an ultrasound, they have a diagnosis, and that's one of the cool things also. I mean, we take care of the kids obviously, but we meet them before they're even born, right? We meet the parents, we talk to them, and we, you know, sort of counsel them on what to expect, and then we take care of them when they're born. So that's pretty cool. The next picture is probably That's a congenital lung lesion. So a kid was born with a cystic lesion of the lung where it inflates too much, and not only does it not function well as a part of the lung, it can compress or push aside the good parts of the lung, and we remove them in the neonatal time frame, or even as an infant, depending on how significant this is. This specifically was a patient that was born in the operating room, so mom delivered in the operating room, not on the labor and delivery unit. The patient was quickly intubated because we were worried about this lung lesion becoming significant in a way that the baby won't be able to breathe on their own, and then we rushed the baby to the operating room. So really, within an hour of the baby being born, the baby was in an operating room being operated on. Baby did well, obviously, and that's great, and it was a very rewarding procedure. The next one, we see a lot of cool stuff. If anyone's squeamish, I'm sorry for these kind of pictures, but this is something called gastroschisis. This is something where babies are born and they actually have what's known as an abdominal wall defect, where the belly button is supposed to be. It's actually that white thing that's hanging off the side in the middle. Yep, that's it. That's the umbilical cord. And rather than it being sealed on the belly, you've got an open wound there and everything is coming out. So we take care of these things also like immediately after the baby's born. So within an hour or so of the baby being born, we're doing something surgically for this baby. This is another one of those intestinal atresias, and you can see that there is this long loop of bowel that ends up in this kind of coiled thing in the bottom right there. That's actually a loop of bowel that got twisted on itself in utero and caused an obstruction. And then that should be in continuity with the little pink thing that instrument is pointing to. That little pink thing, actually, the lower one is the appendix, and the one just above it is what's known as the terminal ileum, where that bowel is supposed to be connected. So we see a lot of cool stuff. Next. This is a picture of me in the operating room as a fellow, and I'm working with one of my attendings. I'm on the left, he's on the right, and he's actually using the robot. So you might hear of robotic surgery. It's not something we do often, but there are utilities, uses for this even in pediatric surgical patients. So we use a lot of cool technology. Now, you all take care of cancer patients, right? Or you've seen cancer patients and you participated in volunteering efforts. This is something called a sacrococcygeal teratoma. This is another thing that a baby was born with, and this is how the baby delivered. So this is something that we resect, or that means we remove surgically, and it's a very rewarding thing that we do. Next. We do some complex stuff, sometimes really nerve-wracking and so forth. This is a baby on something called ECMO, or ECMO, ECMO, extracorporeal membrane oxygenation. You might hear about it, especially in significant lung issues like patients with COVID that might have pretty bad respiratory failure. Even patients that have the flu sometimes need ECMO. And we do this for babies that are born with certain problems like congenital diaphragmatic hernia or other lung issues potentially. I don't want to take up your time. Let's see. So what's my typical day like? Most days we start with a conference in the morning at 7 a.m. We take care of, we have students on our services. So there are educational conferences for the students, for the residents, for the fellow. We talk about our cases and so forth. And usually our OR starts at 8 o'clock every day. Each one of us as a surgeon has a clinic. I do my clinic every Monday. We have outreach clinics, which we do 1 to 2 times per month as an individual. As a group, it's many more than that. We go out to Tallahassee, we go to Jacksonville, we go to Ocala. So we cater to a very large patient population. We do inpatient surgery, we do outpatient surgery, and we have an on-call schedule, or the surgeon of the week. So if you ever come and you shadow while I'm surgeon of the week or one of my partners, you're going to see us running around all day long because there's a lot to do. Specifically, pediatric oncology patients, you might know them as patients with Wilms tumor, which is a tumor of the kidney, hepatoblastoma, or a tumor of the liver, sarcomas, or soft tissue tumors, germ cell tumors, and a whole lot of other things. Those are the solid tumors. We also take care of patients that have leukemias and lymphomas, and for those we may not remove something, but we actually place something in them. Next slide. We put ports in them, right? You might see them. This is how they get their chemotherapy. It's an implanted device that we put in them so they can get their chemotherapy. So we may not necessarily have a surgical treatment for the disease that they have, but they do get some surgery with regards to their treatment plan. Similarly, we have something called lines or tunneled central lines or Broviacs, a whole bunch of different names, but you might have seen kids like these when you volunteered. Sometimes they can't eat very well, so we need to put Gtubes in them. The Gtube is a feeding tube because they can't eat well for multiple reasons. We do this often in the neonatal ICU for babies that are premature and can't eat well or can't eat and breathe at the same time, which is sometimes very challenging. Something we take for granted, but sometimes very challenging for certain populations. So who's on this team? I'm one of 5 surgeons. This is on our divisional website. Besides that, we have what's known as advanced practice providers. I know Nanika was saying that she's going to go into PA school. So PAs or physician assistants and Ps or nurse practitioners. Our team is also comprised of a fellow who is trained in general surgery and now training to be a pediatric surgeon. We've got residents who are training in general surgery. We've got medical students. Hopefully some of you will be medical students in the future as well. So who else? Not just surgeons, we've got a whole bunch of people, right? We work with anesthesiologists, nurses, scrub techs in the operating room, respiratory techs in the ICUs, physical and occupational therapists, social workers, case managers. We're all part of one team, and the goal is to take care of the patient. The patient's at the center, and the goal is to take care of that patient, and we all work together. And one of the beautiful things of taking care of pediatric patients is, I think at least, on the pediatric side of the street, we really work well together. And it's wonderful. Next. So we have fun, like I said. Our operating room, if you come visit, we've got stickers on the walls that are Finding Nemo themed, and this is something where you see Dory, multiple different faces Dory, and it's funny because the OR staff put our names on them very appropriately. So too, some of them are more short-tempered and yell. Some of them are very just sort of chill and relaxed, and I'm kind of the crazy one, as you can see. So, and this is just a picture of our fellow who's in the green scrub cap that's closest to the left side, our division chief, Dr. Isam, who's in the middle, and then the scrub tech, Aaron, who's a fantastic scrub tech, on the other side there. And this is just one of those cases, and this is one of the pictures that we showed at his graduation back in July. Next. So I welcome any questions. I'm sorry if I rambled on. It's really exciting what we do, and I really enjoy talking about what we do. If anyone's interested, I know now is a terrible time for opportunities for shadowing because of COVID, but once things open up again, please do let us know if you'd like to come and see what we do, work with us, shadow, research opportunities, mentorship, somebody just to talk to and ask questions. Anything you need, you let us know. Thank you all. I'll take any questions.
Thank you so much, Dr. Mustafa. That was amazing. The little action figures you think about when I got my tonsils taken out when I was 3 years old, and it let me bring a doll in because I was freaking out, and they just kind of, I think they definitely put anesthesia on me because I fell asleep.
Yeah.
I'm glad to see someone so passionate and so loving about it. That's exactly who we need in this world.
Fantastic.
So
I'll definitely,
yeah, of course. I'll definitely open up in the chat for 2 to 3 questions.
Yeah.
And Hannah is going to go ahead and read them out loud because I
sure.
can't chat right now.
Alrighty, so we have our first question. Someone is saying that they really enjoyed your presentation and they actually want to be a pediatric surgeon one day.
That's great.
And they want to ask specifically, all right,
losing a patient.
Yes, losing a patient, specifically pediatric patient. How has that affected you emotionally in your career thus far?
It's tough. It's tough, right? I mean, it doesn't matter if it's a pediatric patient or an adult patient or whatever age. Death is hard at any age, at any stage. It's something that you got to deal with, right? I mean, part of life is death, and it's hard. So we don't forget about them, right? I mean, it sort of leaves a lasting mark. And just reading that question, I kind of think about some of the patients. So it is tough, but we do it for all the success stories. We do it for all the kids that we're able to take care of. So.
Thank you for that. And then our next question was, were you ever squeamish during a surgery?
I don't think I ever was. No, I can't remember ever being squeamish. Sometimes, especially in the pediatric surgery room, The rooms are kept very warm because kids have a harder time of maintaining their body temperature compared to adults, especially babies, that is. So the rooms are kept very warm. So sometimes we have students or shadows who get lightheaded and maybe not faint, but can get dizzy and lightheaded and sometimes faint. So that's something that sometimes you see in the operating room. Squeamish, I've never personally been squeamish. I don't know why, I just haven't. But you know what? Even if you are and you really want to do this, you'll get over it, right? I mean, you'll learn to, it'll become your new normal. So sorry if anyone was squeamish at pictures.
Alrighty, and then yeah, our last question that we'll be able to ask is, what made you want to pursue this field of medicine?
So I went into my medical school wanting to do transplant surgery, and that was for a personal reason. I went through my medical school, and then my first 3 years of residency wanted to do transplant surgery, went into my research time wanting to do transplant surgery, and then when I came back to my residency, my first rotation back was pediatric surgery. And I don't know, something had happened to me. I was a new father at that time, so my firstborn was born while I was in research, and then pediatric surgery just was such an awesome experience, and just something clicked in me. And even though I was down one path my entire, training so far, I totally switched. So for anyone who thinks that A, you can't do something, or B, you got to do something, know that sometimes things will change. And anyone who's going to be a naysayer, don't listen to them. Do what you want to do. Go after what you want to do. And it's been fantastic. Don't get me wrong. Sometimes work is frustrating. Working in a hospital is frustrating. Health system is frustrating. But we do it for all the positives. I see some other questions about, how to contact me or others or people that are interested. I didn't want to put my contact info up on this because I read in your email you're going to put this on YouTube. So just so it's not like out there in the world, you guys can email your organization leadership, and they can forward on to me and let me know. And I'd be happy to answer any other questions you guys have or entertain opportunities for you. Sorry to take up so much time.
No, that was beautiful. We appreciate taking time out of your busy schedule to do this. That was an amazing presentation. Thank you so much.
Thank you.
Yeah. So feel free to stay if you would like to see the rest. I know you're busy, so if you have to log off, completely okay. But thank you so much. We're going to probably go ahead and introduce the next speaker. So this one's a little near and dear to my heart because I am going to be a PA. So not that I don't appreciate my doctors, I love my doctors, but this one's a little bit more personal. So Miss Ashleigh is actually a certified physician and is currently working at Johns Hopkins All Children Emergency Department down in St. Pete. She's been in Pete's emergency for quite a few years, so she has a lot of knowledge, and she has decided to share that with us today, thankfully, and we're very excited. So Ashleigh, go ahead. If you'd love to speak, we'd love to have you start. Hi, Ashleigh, can you hear me? Okay, I'll just...
It would help to unmute, right?
Oh, yeah, sorry.
Okay, you guys can hear me now?
Yeah, we can hear you now.
I think I would get used to it, for the past 4 months, but still working.
Oh, no, it's okay. The all muting is kind of confusing.
Yeah, so my name's Ashleigh Kervel. I'm a pediatric physician assistant. I have been in peds emergency medicine for 7 years. I did 2 years prior to PA school, actually, in pediatric emergency medicine as well, too. Just before we get into our presentation, I don't really go much about the schooling, but just to give you guys an idea of my career path. So I did the traditional 4 years of undergraduate schooling. I finished that, and I was able to go to several forums like this and other forums throughout the country just discussing medical school, because I always wanted to go into medicine as a provider of some sort. So they told me basically take a year off, work in medicine, and decide if that's what your passion is and that's what you like to do. So essentially that's exactly what I did, is I took some time off to work in the healthcare system, because like Dr. Mustafa, kind of hinted at, is the healthcare system can be a lot and very overwhelming, especially as a provider. You go in gung-ho, like, I'm going to change the world, and then you realize that there's a lot of limitations that are beyond your control. So I went in and started working initially in cardiac rehab with a bunch of older people, and then I got a job in the pediatric emergency department and fell in love with it. And that's when I really started working with physician assistants. And I was like, hey, these people are awesome. They do great work. Their schooling is a lot less time and money, and they're able to practice in fields that they really like. And so I was like, you know what, I'm going to apply to PA school. This sounds like me. This sounds like I want to do. This sounds like my flexibility. You know, I think this is a great compromise, and I really don't need to be a doctor to be fulfilled. And everyone's going to have their own choice. So following that, I applied to PA school, and I'm representing UF class of 2013. So UF was a great experience for me. And then I was able to contact the emergency department that I previously worked in prior to school and get a job back there as a PA, which was really awesome. So today I'm going to go over a day in the life of a pediatric emergency physician assistant and just give you an idea of what my job entails, what I do in the hospital, in clinical medicine, and then outside clinical medicine too, because I think there's a lot of opportunities that people forget about. And then also, to echo Dr. Mustafa, pediatrics is just super fun and it's awesome. So in the emergency department, you are an early bird and a night owl. So we work 24/7. So you can work, many times you're going to work rotating shifts. So we have one at 6 a.m. to 4 p.m. and we have one from 8 p.m. to 6 a.m. So really important if you're thinking about emergency medicine. Remember, you're going to have 24-hour coverage. And so this is going to be a little bit of a lifestyle altering per se. My husband was really nervous about me working overnights and days and having a weird schedule, but it actually works for us and we love it, and we get to travel and hang out with family and friends and still have time for each other. So just be aware of that when you're thinking about certain specialties. So one of the biggest things I am in the emergency department is a treasure hunter. So with pediatrics, you really have to understand what is an emergency and what is not an emergency. So as you can see here, we have everything that I found in ears. So we have beans, beads, popcorn kernels, and they stick them in their nose and their ears. They swallow them, they eat them. So it's really important. So the bad ones I've put on the bottom there. So essentially anything that's acute is going to be your button batteries, and if they're in the esophagus, so in that x-ray picture in the bottom left corner. And then also magnets. So if magnets stick together, they can cause issues with the bowel and they can cause obstructions. And so it's really important that you go after those and know what you're looking for. The other big one is a coin or a quarter. And so kids are little piggy banks and they stick everything in their mouth. And so it's really important to ask if they have anything with button batteries, because it's really not 100% to distinguish between them. And sometimes on x-ray you can see a ring that will distinguish through them. So it's really important. So as much as it's funny and kids do silly things, you have to know what's kind of the emergent ones that you really have to go after and which ones are like, okay, this can stay there. It's going to come out over time. So also with pediatrics, you're a detective, right? So a lot of people either love or hate pediatric medicine. So currently right now we have a PA student with us, and she just is really unsure because she's like, kids just can't do all the tests that I need them to do, and they can't verbalize to me what's going on. And for me, I love that, right? Because I don't have to ask really hard questions and I don't have to worry about being deceived or lied to, because a lot of pediatric patients don't really lie. They're going to tell you the truth, you know. And kids that aren't verbal, you're going to watch them and monitor them. Are they crying when you touch their arm? Are they crying when you touch their belly? Is anything visibly swollen? Is anything visibly bruised? Is anything visibly red? You know, you're going to be listening to the parents because they're with the child all the time and you're a newcomer coming into it. So you really have to be a detective and take in everything, not just what the parents are telling you, because obviously parents can lie, but you're really looking at the patient and you're looking for changes. A lot of times we joke that boys will completely deny they have abdominal pain because they don't want surgery and they don't want to have appendicitis, and they'll sit there and, you know, the middle kid holding his belly, that might be a kid I have, and he says, no, I don't have any belly pain at all. No, I'm fine. I just want to go home. And then you mash on his belly and he's like grimacing and crying. And you're like, I think you are having belly pain and I think you do need surgery. So I really prefer the pediatric patients, but it's very visual as well as good history taking. So your exams may not be exact. They may not be able to do everything that you want them to, but there's a lot of visual cues. Same with tablets and iPhones coming out. If they're able to operate a tablet and an iPhone and they have a head injury, they're neurologically intact. They're able to use their fine motor skills and operate an electronic. So it's really reassuring that way. So that's why I really like pediatrics, and especially in this type of setting. So big one in emergency medicine, I joke, is you're a handyman, right? So this kid with the laceration on his forehead, this is a typical patient we see. A lot of times they're around 2 years of age, and many times it's because they're ambulatory, so they just began walking. Most kids walk anywhere from 7 to 18 months. And so once they're up walking, they run into everything. And what's about child height? Your chairs, your corners of your walls, your coffee tables, your fireplaces. So a lot of times we deal with these lacerations, and they're usually small and pretty easy to close. We also do a lot of suturing if, kids are crazy too, in the sense that they jump off walls, they touch things they're not supposed to, like broken glass. We deal with a lot of dislocations and fractures. So the x-ray you see there is a shoulder dislocation. So that's something that we would put back. Also patella dislocations, or your kneecap when it becomes dislocated. Kids are at a lot higher propensity of that just because they have a lot more ligamentous laxity, which means that their joints are more loose. So they may be doing a pivot or a move and it may slip out. We also do reductions in the emergency department. A lot of times it's broken forearms or broken elbows because they've jumped off a wall, they've done a backflip, they've done a cartwheel, they were wrestling with brother, wrestling with sister. And so you have all these kind of different injuries that we see that we kind of have to put back together, whether it's suturing, whether it's relocating, whether it's reducing their fractures and putting them in splints. So it's a lot of hand-on work, which I also really enjoy in pediatric patients. And I think there's a way to approach them too. A lot of times they are more respectable. The biggest thing is never lie to them. You want to respect them and not lie about what you're going to do. Things may hurt, and they really appreciate that honesty. Interact with them, show them what you're doing so they're not fearful, because a lot of times kids are really responsive and understand that you're trying to help them, and they really appreciate that. So beyond my role clinically in the emergency department, we're also teachers and preceptors as physician assistants. So it's really important in this day of medicine, and as more programs are developing, is that, we have really good teachers and preceptors. And that's why I volunteered to do this, because I want to educate more people about the profession, more people about pediatrics. And we also, we precept, so we have people from different schools that come and work with us. And it's a great way for job opportunities. I also do lecturing on pediatric topics to different physician assistant programs about basic and general pediatric illnesses through GI, dermatology, respiratory, infection, because those all play into it. And we see all of those various things in the emergency department.
So I wanted to, if you don't mind, open this up for people to ask a couple of questions I can read off to you, because we definitely have a couple of minutes, and I'm obviously very grateful you came on.
Yeah.
Because I found you on the PA mentee group meeting.
Yeah.
I think I might actually ask the first question, but how is it being a PA versus an emergency medicine versus maybe other clinical areas like I don't know, like lung transplant or cardiac, or you think there's a difference or?
Right. So I believe the idea of a physician assistant is going to be the same throughout kind of different practices. Essentially, you're there to provide support and extension to the physicians. Essentially, your population pool is getting too big and the workload is getting too burdensome that's placed on the healthcare system, whether it be insurance, documentation, volume of patients that you're seeing. So the idea is to be trained by the specialty that you work for, and then be there to provide and support for them. If you can handle things and take care of things on your own on less acute patients, they may give you the autonomy to do that. If you're seeing more acute or complex patients, they may want you to check in with them and make sure that you're managing them appropriately. If you have multiple acute patients, are they teaching you appropriately on how to manage them? So I think the idea of the PA-physician relationship should translate through all specialties. I think the biggest difference in different specialties is going to be your schedule, your work life. I think surgery specialties are going to be different because it's going to depend if you're in the OR and first assisting versus just being clinical. So there are some differences there, but I think the idea should essentially be the same.
Okay. So we have another question. Do kids ever mistake you for a doctor or a nurse? How do you usually explain your position/role to your patients?
So I just word vomit every day. Like, my name's Ashleigh Kervel. I'm one of the physician assistants that work in the emergency department. What brings you in today? So I just have a scripted thing. I get called doctor all the time. So you're the doctor. Well, I'm the physician assistant. I'll be taking care of you today. I will be your provider today. I can correct them till I'm blue in the face and they still may call me doc. They will be on the phone and they'll be like, oh, the nurse just got in the room. And I'll be like, oh, I'm actually your physician assistant. You know, what brings you in today? I'll be taking care of you. And then they'll say, well, where's the doctor or what's going on? I'll say, oh, I work with my attending physician. I'll let them know if you have concerns, or, you know, I work with them. They'll stop by to check on her. We'll get started. It really just depends on your patient population and how they see it. We're also guilty of it too as providers. I call everyone mom and dad in the pediatric emergency department. They may be grandpa, uncle, aunt, relative, caregiver, foster mom, but to me, they're mom and dad. So they could also correct me. So it kind of goes both ways. But I do make sure that I do not imposter anyway. And I try to be as correcting as I can without being disruptive of their care, I guess is a good way to put it.
Okay. You feel okay to answer a couple more questions?
Yeah.
Okay. So as a PA, you can go into surgery if you want to?
Yeah. So essentially, physician assistants are really utilized in surgery. So you can be a surgical, so essentially there's kind of two different roles. So like Dr. Mustafa said, so he works with APPs. So it can be one clinical. So if you have fellows and residents, you may not be in the OR as much in the operating room because it's more of like a teaching facility for those patients. And so you may be doing more clinical time, more rounds, more consult calling, and kind of running the rest of the group, right? So if you're in the OR and you get a consult to the ER, the surgeon's not running to the ER, it's their APP. And because the surgeon's with the resident and the fellow and they're already operating on some other kid, so the APP can evaluate the patient, get them put on the board, order antibiotics, and get them set up all for pre-op during the entire time that the surgeon's in the OR. The other way you can look at it essentially is you could be a first assist. So such as Dr. Bladowais is talking tomorrow. He had a nurse first assist, but there's also PA first assist for cardiac surgery. And so basically you are trained by the surgeon to do the surgical procedures in a first assist role. So you're not the generalized surgeon, but you may help with suturing, holding, tacking, removing things. So you're going to be kind of their partner or support when they're doing operations.
Okay, and I think we'll ask one more question. So what are some of the challenges you face day to day in the ED?
So the challenges, what kind of challenges? Do we want to talk medical? Do we want to talk healthcare? So everyone says with pediatrics, well, you have to deal with the parents. Parents are fine. The way I see it is essentially, this comes back to my thing about making sure you want to go into medicine. Do not be jaded about medicine. If you get jaded or you became angry or you think that people are there for no good reason, you're going to hate your job. So essentially, how I think about it is that these parents were so concerned about their child. They put them in a car seat or in the back seat of a car and they drove to an emergency department, whether it's 2 in the afternoon or 2 in the morning. So, you know, I really try to listen to their concerns and take care of them if they're validated concerns. Sometimes they aren't, and sometimes they want me to practice medicine that I'm not comfortable practicing. The other day I got yelled at for not giving a breathing treatment for nasal congestion. I said, that's not what breathing treatments are for, and the lady just left in a Hufflepuff. I couldn't appease her, but also I'm not going to practice that's not appropriate. You know, sometimes going back to Dr. Mustafa's questions, you in the emergency department, you deal with death. You have horrific car accidents or kids that don't survive things. And that's really hard, but you also have a group that people are with you. Sometimes one of the hardest things is you don't have the answer. So everyone wants an answer of why their kid's sick or why their kid's doing this or what's happening with them. I don't know. And that's going to be the hardest thing. My job is to rule out any emergency. Are they having something life-threatening that's going to threaten their life? No, then I have to move on. And I can't spend, 20 days figuring it out, unfortunately. And I think that's really hard too for some people to accept.
Okay, Ashleigh, thank you so much for coming and talking to us today. Really appreciate it. I'm sorry you can't get to all the questions, but
no, that's fine. Same thing. If they just want to contact you and you want to send them my email information, I'm happy to answer any more questions, especially about PAs, what they do, how they do, pediatrics, emergency medicine, whatever.
Of course, I'll make sure they have it since you feel comfortable with that.
Yeah.
But thank you again so much. Again, I want to be a PA, so I really appreciate it.
Yeah, no worries.
But thank you. If you want to stay, go ahead. If you have things to do, I completely understand.
All right.
I'm probably going to go on and go into the next speaker. So our next speaker is Jennifer Thelen. She's actually a registered nurse, certified in pediatrics emergency nursing. She's a nursing operations manager and oversees the Children Emergency Department and Level 1 Trauma Center. So today, Ms. Jennifer will be sharing her experience with trauma within pediatrics. So we can go ahead and give that for her.
Everybody see me okay and hear me?
Yes, we see you perfectly.
Okay, so I apologize about my appearance. I was actually in staffing all day today. We were quite busy. Still have my headband on with my little masky things to hold my mask on, so I look like a wreck. But I will share some fun things with you guys. Thank you so much for asking me to speak. I too, like Ashleigh and Dr. Mustafa, I absolutely love pediatrics. I don't feel like I am ever going to work. I have an amazing team. I love our patients and just thoroughly enjoy what I do. A little bit about my background that I don't have on a slide. I initially graduated from George Mason University in Virginia with a health science degree. I thought I wanted to go into physical therapy and then realized I did not want to do that. So I researched both PA schools and nurse practitioner programs. Ended up going back to Virginia Commonwealth University for an accelerated nursing program where I would finish with my family nurse practitioner. 1 semester away from finishing that, we had a family emergency and I was not able to finish that. And we then, I finished with my RN, but not my nurse practitioner, and started in adult ER medicine, which I also loved, but nothing like pediatrics. So I did 4 years in adult ER. And then after moving to Florida, I did 1 more year in adult ER and then transferred over to Arnold Palmer once they opened up their pediatric emergency room. And I have been there for 14 years. So I was an RN at the bedside first. And I then became an assistant manager on night shift. I did 7 years of nights. And, Ashleigh spoke to all the crazy shifts of the ER. And I think everybody kind of has their shift that they like to work. So moving from a night shift from 7 years and now into a Monday through Friday type job. My kids like me better. They said I'm not grumpy and yelling at everybody anymore, but I definitely enjoy the day shift better. Night shift is definitely kind of their own breed. I love my night shifters, but you've got to be able to survive with very little sleep. So where I am right now, I'm in the emergency room at Arnold Palmer Hospital for Children. We are based out of Orlando. Florida is very blessed in that they have multiple children's hospitals across the state, including All Children's, Shands, Miami, and there's several more that I have not mentioned. So we are one of the children's hospitals in Central Florida. We are the Level 1 Trauma Center in our area. So we get patients from all over and the surrounding counties. I think we serve 11 to 12 surrounding counties. You can go ahead and move on. You can move on again, sorry, just my info. So we are verified by Florida Department of Health as a Level 1 Trauma Center, as well as the American College of Surgeons as a freestanding Level 1 Pediatric Trauma Center. We have all sorts of different people that work in our department. We have board certified peds emergency room physicians. We have adult emergency room physicians that sometimes float over to the peds ER. We have a peds ER fellowship program. We have residency programs in both ER and pediatrics. We have a surgery residency program, a nurse practitioner residency program, and the list goes on and on. I think I go on to the next page here. So all of my RNs, I oversee about 110 team members. I do not oversee the physicians, the physician assistants, or the nurse practitioners, but everybody else falls underneath of me. All of my RNs have at minimum a BSN with their CPEN certification, and that's a certification in certified pediatric emergency nursing. We also have an EMS liaison and a pediatric readiness coordinator, which I'll speak to. We'll actually talk a lot about that role today. An injury prevention coordinator, paramedics, EMT, chaplains, social workers, respiratory therapists, and then we have our own critical care transport team. We see approximately 55,000 children per year coming to our emergency department, and like both of the other children's hospitals that the previous speakers come from, we see kids for all sorts of reasons. Some of us use us as their primary care physician because they don't have a primary care pediatrician. We see kids that have cancer. We see kids with hematology issues, with orthopedic issues, chromosomal abnormalities, you name it, we see it. I have to look up a lot of things because there's so many syndromes and such that I have never even heard of because we see rare, very, very rare cases. I'm going to speak a lot about trauma today. So we see approximately thousands of kids coming in from trauma. So you talk about falling off a scooter or falling and bumping their heads. Those are considered traumas, but the severe traumas that we admit approximately 900 traumas per year and see approximately around 300 trauma alerts per year. And if you don't know what a trauma alert is, I apologize. If you see a child or a dog flying by, I've just walked in the door a little bit ago, so it's a little bit chaotic. So a trauma alert is the highest criteria for trauma patients that are being brought into us by EMS. And those patients are usually have a long bone injury, they have difficulty with their airway, they have penetrating injuries or altered mental status, things like that. And then they're called a trauma alert. And go on. Okay. So interestingly, our mechanism of injury, our most frequently seen mechanism of injuries have changed since COVID. So prior to COVID, our most frequent mechanisms of injuries were falls, auto versus pedestrians, where a child may be walking across the street and got hit by a car, or they're riding their bike and got hit by a car, and then MVC. Today, we actually had 4 ambulances come in within a matter of 20 minutes. 2 cars were in a collision, and we had 5 to 6, I think, pediatrics, and we take adults sometimes as well. And so we had an adult mom with them, and none of them were restrained. So all of those patients came in to us to be checked out for various injuries. So post, I apologize. Okay, sorry. That was my youngest. So post-COVID, our mechanisms of injuries have shifted a little bit, and we have definitely still seen MVCs, but if you look at number 2, 3, and 4 there, gunshot wounds have increased, burns have increased, and non-accidental trauma have increased. So we have done a lot of research into this, and at this point, we're attributing it to people not coping well with what's going on right now. Some of these gunshot wounds have been self-inflicted, and some have been, in some of the areas around Orlando that are not so great areas as far as safety. Wednesday, we had a drive-by shooting and received a 14-year-old and a 15-year-old come in with one succumbed to his injuries, and the other one is up in our PICU right now. excuse me, we've seen burns, again, non-accidental and accidental, and then non-accidental trauma. Those are patients that come in that have been injured by someone or something, not by accident. So shaken babies or kids that have been beaten, broken arms, broken ribs, things like that. So our population of those types of patients have increased as well, which is quite sad. And you know, you talked about death and dying, and that's something, unfortunately, we see very frequently. And when it's on purpose, it makes it even harder to cope with those things. Today's Wednesday, so a week ago today, we had a mother who drowned her son in a retention pond, and he came into us. We tried to resuscitate, but he had been down a long time. We were not able to save him. And then we had to leave that child and go into another room and take care of a child who maybe came in for something very minor, like congestion, but you have to treat them the same, and you have to be able to rebound and to put those emotions aside for a bit and continue on for the rest of your shift. So that can definitely be challenging. So as a level 1 trauma center, part of what we do is go out into the community and educate the community about ways to prevent injury. And so we take those high, so like our number 1, 2, and 3, and we go out into the community and we help do some proactive things with that. So drownings, we see a lot of submersions. So infant swimming classes, making sure that people have safety fences. If they can't do a safety fence, that you always have somebody watching the pool. Bike helmets while they're riding their bikes or scooters. Excuse me. We also do work with, the Children's Safety Village in Orlando, where people come in and they talk about stove safety, again, swimming, how to walk across the street correctly, things like that, making sure we're buckling up the kids in the car seats properly. Today, they weren't even in car seats. All 4 kids were thrown in the back seat. There was a scooter in the back seat that became a missile, hit one of the kids in the back of the head. So just, you know, being smart while we're driving, staying off of the cell phones and, you know, music down, things like that. And then we also do a lot of work with what we call pediatric readiness in the emergency departments across the surrounding counties, those that are part of Orlando Health and those that refer to us, as well as EMS agencies. So we do a lot of work on how to take care of kids. And this is just a little bit about Florida's Peds Ready. And the other children's hospitals are very good at taking care of pediatrics. But when a child goes into an emergency room that doesn't specialize in pediatrics, I'm not saying that they get bad care by any means, but sometimes they don't have the equipment that they need, the medications that they may need, or the people who are really trained to take care of kids. So we go out and we help make sure that they have the equipment to take care of the little tiniest of babies up until, you know, teenage kids. Teach them how to dose medications appropriately, because in the pediatric world, everything is by weight. So in the adult world, all the dosing is the same, but with kids, it's by weight. So everything is in kilograms. So you have to know how to mix those medications and making sure that you have an accurate weight so that you don't overdose or underdose a child. Okay, so into some more fun pictures. This guy here, he is still nameless. We just got him. He is a high fidelity mannequin, and he pretty much does it all. He moves, he talks, he cries, he blinks, his colors, his skin color changes, he breathes. So we can practice all of our trauma skills on this guy. We take him with us everywhere we go to all the other, whether we're going to a firehouse or we're going to another emergency room. Previously, our old mannequins came with us. Now we bring this guy. So he is really cool, and we get to do a lot of fun stuff with him. So we do a lot of training scenarios in our emergency department and other emergency departments as well. So this guy was sitting in my chair when I came in the office last week and scared me half to death. They had him talking from the other room, and when I walked in, he looked like a real kid just sitting there. So my team members think that they're funny, but it scared me quite badly. If we go to the next one. So this was one of the scenarios that we did with I believe this one was with, it might have been with Osceola Fire Department and one of our freestanding emergency departments. So you see, we brought our mannequin along, and then we give them a real life scenario, and they have to act just as if it was a real patient. So we start with EMS, and then we load them up into the ambulance, and then actually go into the ER and continue the scenario on until we feel like we've met all of our objectives. This is the same crew once they're in the emergency department. So then our physicians, nurses, RTs, everybody gets their hands on, and we actually go through real vital signs, giving fake medications, etc., just like it was the real thing. This is actually our emergency department. So this is some of my team doing, again, a different scenario. This was Reedy Creek, the Disney group, the Disney Fire Department bringing in a patient, and then our team taking over. And then this was one we did just a couple weeks ago. We just acquired St. Cloud Hospital. So we put together some great training scenarios for St. Cloud EMS and then St. Cloud Hospital. We had Air Care, who's our air transport team, land at the scene, and we actually loaded patients. This was a multi-patient. You can kind of see one of the patients there, and then there was a couple hanging out the back of the van. So we had 3 different EMS teams working on 3 different patients. 1 went by air and 2 by ground, and we actually took the patients to the hospital. I got to jump in the back of one of the ambulances and ride in with them, which was pretty fun. This is our trauma room. This is a real life scenario here. We have 4 bays in our trauma room, and we had 2 trauma alerts going on during this time, but I put this in there just so you can see if we have multiple traumas coming in at one time, how many people are at the bedside. And to be honest with you, this isn't even really a lot. Sometimes it's quite a few more people. So crowd control definitely needs to happen. Communication can be tough at times. And right now, with everybody being in, everybody pretty much in the ER right now is on isolation until proven otherwise. So we have our providers wear North masks, we have N95s, and then regular masks over top. So it makes it super challenging to hear orders and the assessment being done so that we can document and get the meds appropriately. And then this one is just another one where we put patients, we like to get super creative and put patients in cars in difficult places for them to really have to, you know, use their critical thinking skills to be able to do what's best for the patient. And then let's see, again, our trauma room here, 2 bays running at the same time. We have some fun stickers on the walls and on the ceilings because kids are usually on their back and looking up or looking across the room. So this is where Child Life would come in into play. If you're not familiar with them, they are amazing, and they specialize in just keeping the kids calm and distraction techniques and teaching them about what procedures they're going to have done. So they're amazing. We have chaplains at the bedside, social work, and we allow parents in the trauma room. I think it was Ashleigh that mentioned, you know, people say, oh, you have to deal with the parents. We do. However, most of the time they are amazing, and they're your best friend because they're going to tell you all about their child because they know best. And we allow the parents to be in the room while we're resuscitating or during trauma alerts, so long as they are able to, you know, not be so distressed that, you know, they end up going on the floor or something like that. So we have somebody assigned to them, and a medical person who can tell them exactly what's going on, you know, throughout the process. And I think that is it. So I know that was a whole lot in a little bit of time, but like I said, if you're interested in pediatrics, it is amazing. I couldn't imagine doing anything else. I would never go back to the adult world. And, you know, you do have such you have those families that just tug at your heart. And I have so many families that I continue to keep in touch with years after we've taken care of them in the trauma room or their cancer diagnosis. It's fun to watch the kids grow up and they come back and they thank you and hug you. And it's just super rewarding. And like I said, I couldn't imagine doing anything else.
Thank you so much, Jennifer. That was really awesome. Thank you so much also for coming and speaking. We really appreciate your time. I know.
Well, thank you for asking. I was excited to share.
I know. I'm a PCA, a patient care assistant at Shands, and my nurse
manager
is like my best friend. So it's kind of nice.
Yeah, and I'm blessed in my role because I am I am leadership, but I am at the bedside as much as I can be. I think that's servant leadership is what I believe in. So my team needs to see me out there helping, especially when things hit the fan like they did today. That I'm in the trenches with them. It's appreciated.
Do you mind if I have one question? I have someone who just has one question to ask.
Sure.
Yeah, thank you. So it says, hi, I'll be going back to school to get my nursing degree through an accelerated program. Did you think having experience and education in other areas gave you an advantage in nursing school and career? Or do you have any general advice for the program / starting your nursing career?
I do, because I felt like I grew up a little bit in that time, and I knew for a fact that that's what I wanted to do. The accelerated program is very fast. So I did not work during that program. It was a full-time, it was pretty much a full-time job, a lot of clinical hours. But I felt like going to school previously allowed me to, like I said, mature a lot and know for sure that nursing was what I wanted to do. Because when I came out of undergrad, I was like, okay, what the heck am I going to do with my life now? And I actually went back and got my EMT first and worked in an ER as a patient care tech. And then that was when I explored both PA school and nurse practitioner school. So I think the maturity for me was the biggest thing.
Okay, wonderful, Jennifer. Thank you so much for coming here again. I know I keep saying that, but I'm just very
and I apologize. My voice is a little hoarse. It's been a long day, and I had a kid fly by at one point in time, but I apologize for the distractions, and thank you so much. Thank you. Best of luck to everyone.
Thank you, Jennifer. Okay, so we are going to go ahead and go to the next speaker. Hannah, if you want to introduce.
Yeah. Well, first of all, thank you to all of our incredible speakers who have presented so far. It's been really amazing. And we just want to end the night with our final speaker. Today we have Mr. and Mrs. Ron and Diane Farb. They are the co-founders and co-executive directors of the Climb for Cancer Foundation. They've been longtime partners and supporters of the Footprints Buddy and Support Program, as well as a lot of other UF student organizations who are actually present in the audience today. And so a little bit about Mr. Farb. He has climbed extreme heights to advocate for his cause, and we are so grateful for all of the work that he has done to support those affected by cancer. So with that being said, please give it up for our final speaker of the night, Mr. Ron Farb.
Thank you so much, Hannah and Nanika. We really appreciate it. It is absolutely wonderful to be reconnected with Footprints. It's one of my favorite organizations. It's actually the first organization at UF that we partnered with, and it's just such an honor to be included in this program. So I thought I'd start off, first of all.
We're trying to share the screen here.
Okay. Well, I can tell the story.
All right.
Sharing.
All right.
I thought I'd start off by giving you a little history of the Climb for Cancer Foundation and how it was conceived. 30 some odd years ago, I was asked by friends of mine that started a camp for children with cancer up in Georgia called Camp Sunshine to come up there and volunteer for a week. I did, had a spectacular week, but realized that I had to do more than just volunteer that 1 week and to write a personal check. So each year I would go up and I would try to think of a way to raise more money for them. And in 2001, I decided that I would continue on my quest to climbed the 7 summits, the highest mountain on each of the 7 continents. I had climbed Mount Kilimanjaro, was before the foundation and was not a fundraiser in 1992. So again, in 2001, I went down to Argentina and climbed a mountain called Aconcagua, the highest mountain in South America. Actually, the highest mountain in the world outside of the Himalayan range. It was 23,000 feet. Hannah, it looks like Diane is having difficulty.
Yeah, it's not letting,
with the
I'm
screen,
not able
so-
to share the file. So if you can pull, do you have the presentation?
Yeah, so I can go ahead and pull it up real quick.
Yeah, that'd be fine.
And you can
Yeah.
keep talking while I'm getting it or anything
That'd
else.
be great. So I climbed Aconcagua successfully and raised a good bit of money that I gave to the American Cancer Society in Jacksonville, where we were living. And then the next year, I went up to Alaska and climbed Denali, 20,320 feet, and raised another boatload of money and gave it to the American Cancer Society again. But we wanted more control over where our money was going to go and exactly how it was going to be used. So we got our 501c3, our nonprofit status. And that was in 2003, September of 2003. Here are a couple of pictures. I think that you have it on the screen now. The picture on the left is me standing on the summit of Denali in Alaska. And the other 3 pictures are of me on Mount Everest in 2005. The thing that I'm most proud of about that climb is we raised just a few dollars under 200,000, and that helped out a lot of children with cancer. Okay, Nina. Diane?
So our foundation has funded or created several programs at UF Health. We're primarily focused on providing support to the patient and the family. We do fund some small research grants, but primarily we focus on the cancer patient and the family. We like to think that our small gifts fill in the cracks left by much larger organizations. So these are things that might not otherwise be fulfilled. You can go to the next slide.
So the program that resonates most with our donors is called Harriet's Helping Hand. It's named after my sister, who I lost to cancer. And just as a little side note, she became the first person to climb Mount Kilimanjaro. She did it with me in 2008 while undergoing chemotherapy. She passed away the next year, and the following year, 2010, I took her ashes up to the summit of Mount Kilimanjaro, where she lives today. But the program defrays the cost of treatment by providing food vouchers, gas cards, and lodging to cancer patients and their families. Just to tell you how that came about, she was treated at the Lineberger Cancer Center at the University of North Carolina. And I went up to take her to infusion one day, and she was sitting in the infusion chair, and the chair on either side was empty. And when I asked the nurse why, if it was a slow day, she said, no, we were supposed to be full. And I said, where are they? And she said, Ron, they can't afford to come. And I said, well, what do they do? And she looked at me and she said, unfortunately, they die. And that hit me like a ton of bricks. And I said, we have to do something about it. So came here, and that's when we started providing the gas cards, and then added food vouchers because many families, I noticed, were eating leftovers off of patient trays and couldn't afford to go downstairs to the cafeteria or Wendy's or Subway or what have you. And then lodging is something that we added, and we'll tell you a little bit more about what we've been doing since COVID.
Next slide, please. We also have a program called the Butterfly Connection, and it was originally created and funded by us, and we partnered with Arts and Medicine at Shands, and it provides cancer patients and their families an opportunity to visit the butterfly rainforest at the Museum of Natural History free of charge. This program is actually being expanded, especially during COVID, they're adding some virtual programs to the Butterfly Connection so that patients in the hospital can see the butterflies in the rainforest. So it's a terrific program. Next slide, please.
So helping children with cancer during COVID. This has been the most unprecedented time in all of our lives. The volunteers, you and me, I've been volunteering in pediatrics for the last 8 years, unable to visit the patients now, and the playroom where you do most of your work is off limits, as you know. So the children have to remain in their rooms, and the toys and games that have been that are in the playroom have been sidelined due to infection control. So we funded this program that's going to provide individual art supplies, sensory toys, and activities, small toys and prizes to the inpatient pediatric cancer patients. Hopefully, you guys will be back soon. I'll be back soon, and we'll be able to play with the children with these toys and supplies that we're going to be providing.
Next slide. We also support a program some of you may be familiar with called Streetlight. It's designed to meet the psychosocial needs of the young adult cancer patients. Adolescent patients already have, well, adolescents already have enough problems in their lives, right? So you add a disease like cancer, and it's just another layer. So this program matches them with individuals who have been through cancer as an adolescent and can help walk them through the process. Next slide. With some funding from us, they created the Streetlight Gaming League, which is really cool. We purchased game consoles for patients to have in their rooms, and these game consoles provide them the opportunity to communicate with people outside of their hospital room. They can communicate with the patient in the room next door, or they can communicate with their family. They also have game nights where they have competitions. They can compete with one another on various video games. There are prizes. So it's just another way for them to stay connected with one another, which is even more important now during COVID since they are isolated in their rooms. Next slide.
So Child Life, which we're all familiar with. On the first day when the pediatric patient finishes radiation, they now receive a bucket of small prizes. Each time they return for treatment, the child brings the bucket with them to be filled once again. They positively associate these toys with each session of radiation. This is something that Child Life asked us to fund, and we were very excited about it to make that experience so much easier for the child.
Next slide. So we work a lot with the Ronald McDonald House. We have provided funding in the past. It has been closed initially during the pandemic. They are just now reopening and allowing families back in. But those families who stay there are asked to donate $15 per night during their stay, but many of them can't make that gift due to their medical bills and other circumstances. So we sponsored a room at the Ronald McDonald House for cancer patients, and this will allow them to stay there free of charge without having to worry about that $15 per night donation. Next slide, please.
So the Brandon Ling Memorial Sports Camp, we have done 15 straight years. This was the first year we were not able to do it because of COVID. Actually, it was going to be held in a few weeks. But it's a opportunity for a child to be a child for half a day and to play sports with their heroes, the student athletes at UF. We get over 150 UF student athletes every year to come out and play with the children from all the sports, unless the team happens to be out of town. It's, as I say, a time when they can forget about their bald heads like little Bailey here and missing limbs and just be a child. It's our favorite day, and it just hurts so bad that we were not able to provide the camp for the children this year. But possibly if we do see a vaccine soon, we might be able to reschedule it for the spring. But the other thing with this program is, in addition to the student athletes, we get volunteers out there, and we sure hope that we can include Footprints the next time we have the camp, because I guarantee it'll change your life. The great story is you take a little child like Bailey here, who now has a full head of hair and a healthy body, and it's just wonderful.
Next slide, please.
All right, just a little bit about some of the events that we
Normally have.
Obviously, we haven't been able to do this year. Up in the top left corner is our Hogtown 5K beer run. We get over 500 runners every year. It's run out in Hale Plantation. And
it was supposed to have been in March, and of course that was canceled, and we're not too sure about this spring, but we hope that we'll be able to hold the event.
And we can always use volunteers
Always.
at that run, because it's a big event. Below that, you see the two little wiener dogs running, and that's our Halloweener Derby, which we run in Halloween, the month, actually the week of Halloween. And absolutely everybody's favorite. It's the cutest thing you've ever seen in your life. We, in addition to the wiener dogs, we added the running of the Chihuahuas as well. So it's a great event. And then we've already spoken about the sports camp, which was to be our 16th year, but hopefully we'll get it back on the books soon.
Next slide.
Okay, so every year I take a group of students up to North Carolina, Tennessee, and Virginia, and we do hiking, camping, and climbing. We climb the high points of those states. This is the very first group that I took, and this happens to be a Footprints group. On the right is a young man named Michael McNeely. Michael was a rock star at UF, not only a great student, but was on the football team as a walk-on, earned a scholarship, scored the winning touchdown against Georgia on a fake field goal. Jomar Duran, next to him, Jomar was a member of Footprints and AED, and he is the one that connected the Climb for Cancer Foundation with both groups. A great young man. Michael, by the way, Michael McNeely is now a doctor and a captain in the Air Force. Jomar is a nurse, has been nursing at the University of Florida, but is now at Texas A&M, where his wife is getting her PhD. And a great group of young people that I still am connected with, and just so proud of everything that they did while they were in Footprints, and now that they're physicians and nurses.
Next slide, please.
I think that was the last slide that we had.
Yeah, okay.
Well, actually, there was one slide that gave all of our social
It may have
media.
been added.
Oh, I'm sorry. I can also.
You know what?
That's okay.
It was added after we sent it to you. And
Oh,
You can
okay.
you can go on climbforcancerfoundation.org, and you'll see the icons for all of our social media platforms. And there was a slide in there that was just something that I added, and it said, "Please vote. I tell all students today, please vote. So with that, I think we're done, but happy to take any questions that you may have.
Yeah, again, thank you guys so much for speaking. Everything you do is absolutely inspiring. So we're glad you took time. I know you're not even in Florida right now, so thank you for coming. Yeah, if anyone has any questions, please ask. We've got a few comments here. It says, I love and miss you, Ron from Kia.
Oh.
And then Shantae Lewis from AED, she said, hi, and we miss you too, and so inspiring. I just wanted to share that and read that to you guys.
Thank you so much. I spoke with Kia yesterday for the first time in almost 6 months.
Oh, I know, it's been very different lately.
Very different, yes.
Let's see. So I got a question that says, how do we get involved?
Sure. Unfortunately, right now, because we are not able to run any of our events, there's really not much to do. I'm hoping that when we are able to bring back our run, and by the way, Kia ran in a run the last time we had it, bring back our run, bring back the Halloween Derby, bring back the sports camp, we not only would welcome you, we would really appreciate your involvement with the events, because it helps us put on a much better event. And then I would love to do the same thing that I do with AED now, and that is to include you on the trips that we do. We not only do the North Carolina, Tennessee, Virginia trip, but I do an international trip. We did Costa Rica and El Salvador, and they are both adventure and service. So as soon as we're able to bring back events, I'll be in touch with Hannah and Ninika and let you guys know. Love to have you.
You can also go to our website, climbforcancerfoundation.org. There's a link to all of our social media from there. You can sign up for our newsletter, which is sent quarterly, and that will always have information. If the run is going to actually happen, it will be in that newsletter, and there will be an opportunity to sign up to volunteer. There'll be a link on the page that if you're interested in volunteering for the run to help participate, you can sign up on that as well. So the newsletter and our social media is the best way to keep track of what's going on.
Yeah, and we'll definitely make sure to share those resources with everyone and everyone who participated today, because I think this is an absolute great foundation to be a part of. So thank you guys again so much for coming and speaking today.
Thank you for asking. It was our pleasure.
Of course. And Rob, I think that's what we have for today. I think Hannah's going to share some resources with us.
Yeah, I want to say thank you again to Mr. and Mrs. Farb for being here today, and for all of the incredible work that you have done and continue to do for these kids and those affected by cancer. So really, thank you so much. And I know someone dropped the Climb for Cancer website in the chat. So for anyone who's interested in checking that out, just head over to the chat. But just to sort of wrap up the end of today's event, we know that we heard so much from all of these different speakers about the way that they've been able to contribute to pediatric health, and we wanted to sort of give our audience members a way that you can contribute to supporting pediatric patients. So with the end of the month happening, Footprints has been partnering with the Alex's Lemonade Stand Foundation to participate in their The Million Mile Challenge. So we've been fundraising all month to raise money for pediatric research. So if you're interested in joining our team or donating, here's a QR code to our team. And additionally, this Saturday, our Organizational Advancement Committee is putting on a virtual event where you can, wherever you are, run, bike, or walk however many miles, and we will, at the end of the day, see how many half marathons we have run together. So this is a way to sort of participate, socially distant, but still raise awareness and raise money for the cause. So if you're interested in participating, we'd love to have you join us in this day. And if you want to be featured on our social media, you can just email us at uffootprints@gmail.com with any photos or videos of you participating in that event.
Okay, I just want to give a final thank you to everyone who spoke, everyone who participated. I'm so glad to have you here. I know me and Hannah have been working really hard on this, so we're very grateful for everyone who showed up. And this has just been an amazing night. However, the fun isn't over. This is just part one of a two-part event. Tomorrow, September 24th at 6 p.m., we're going to have a part two of a pediatric forum. Now, we're going to have 4 brand new speakers. So I highly encourage you guys, if you can come, please come, because it's going to be basically a whole nother event with a bunch of wonderful speakers, including some former patients who are very, very excited to have. So I think it'll be very fun, very educational, and I very, very encourage you guys to come. It's going to be a separate Zoom link, and we have that on our social media, our Facebook, and we'll post it again for you guys to see. So don't click on this link, and it will be a separate Zoom link. So again, I just want to thank you guys for coming. I know we were pretty nervous, but we think it turned out pretty well. So I'll let you guys go off. Again, if you have any questions, please email us at ufoprints@gmail.com. And if you want to check out our website, you just look up UFO Prints on Google and you'll find our website. But that's pretty much it. I'll let you guys go. And thank you guys so much for coming. And I hope to see you tomorrow as well.
Thank you all so much. Stay safe. Have a great night.